Good morning, everyone. I'm Dr. Imran Shaikh. I'm basically a GI oncosurgeon. I'm working with Hinduja Hospital, Mahim. And I have done my education all in Mumbai. That is my MBBS. Then I did my DNB General Surgery. And after that, I completed my super specialty in DNB Surgical Gastroenterology. After that, I went to England for my hepatopancreatobiliary surgery fellowship. I've also done GI cancer surgery or oncosurgery fellowship from Korea, and I'm also done robotic surgery fellowship from London, University College Hospital, London. After that, right now I'm practicing for last 10 years. I'm recently attached to PD Hinduja Hospital, Mahim. My key areas of interest are advanced laparoscopic surgery, hepatopancreatobiliary surgery, and GI cancers, where I do all these cancer surgeries by minimal access, that is laparoscopy, robotic, as well as sometimes standard open surgeries. So uh, nowadays you must have seen that this colorectal cancers has been quite a common disease, and we have to have the awareness about it. This month, coming month, that is March 2020, has been declared as a colorectal cancer month, and all over the world we are celebrating that. And we decided to choose this topic for the awareness activity. So this is about the colorectal cancer awareness for the common people. And what is colon and rectum? So we'll just go into detail of it. As you can see a slide, the colon and rectum is made up of a large intestine, also called as a large bowel. There are two types of bowel: the small bowel and the large bowel. And this is a part of a digestive system. And if you see, the food comes from the food pipe to the stomach. From there, it goes to the small intestine. From there, it goes to the large intestine, that is called as a colon. So the small intestine is a very long organ, which you can see at the center of the abdomen. And then the large intestine, which is been divided into the different parts called ascending colon, transverse colon, sigmoid colon, and then rectum. Rectum is nothing but a stool bag where we store our stool, and it has been evacuated from below. So this is called as colon and rectum, and they are prone for cancers. The risk of cancers is pretty high nowadays, and being such a long organ, the length of a colon and rectum is almost 1.5 meter, and that's why the risk is more. As bigger the organ, more the tissues, more the cells, and more the risk of a cancer. So what is the most of the large intestine is made up of a colon, and it is about 5 feet long, also 1.5 meter long. So you can see it occupies almost whole of the abdomen. It goes in the all the quadrants and corners of the abdomen. It is essentially placed all around, with the small bowel at the center and large bowel of the colon at the periphery. The parts of colon are named by food traveling through it. Like you can see on the right side, the cecum. Cecum means a collecting bag. So when the small intestine digests the food and it forms a liquid stool, the liquid stool eventually come to the cecum, where it gets collected. So cecum is the first part of a small intestine where the liquid stool get collected, and then the ascending colon. As the stool ascends, it goes up. That's why it is called as ascending. Then it transverses from right to left. So this colon is called as a transverse colon. And then it comes down, it's called as a descending colon. So the stool goes from cecum, goes up, then transfers from right to left, from left again down. Then comes the sigmoid colon. Sigmoid means it is a sigma shape. You can see this is like a S shape or sigma shape colon. So that's what is called a sigmoid colon. And then this is a rectum, which is a stool bag, and through which we pass our stools out. There is a control mechanism at the lower end of a rectum, which is called as anal sphincter. And sometimes these sphincters get involved, or sometimes these sphincters also at risk of getting cancers. So it is very important. It is very important to not to miss that the anal sphincter, which is an important part of a colorectal cancer. How do the colon and rectum work? The colon absorbs the water and the salt, and remaining food matter goes to the small intestine, that is called a small bowel. So it is a very important function, where colon is not is a digestive organ. It just transport a liquid stool which is formed into the small intestine after digestion and absorption. What remains is called as a stool, which is in the liquid form. Once it comes to the right side of the colon, the water and the salt only get absorbed from the colon, and the liquid stool becomes the solid. And that's how it is crossing through the 1.5 meter of a tunnel. All this waste product, after removing the water, becomes solid, and they goes to the rectum. In the rectum, which is the final 6 inches, around 15 centimeter terminal part, which is also called as a stool bag, where they get stored. And once there is a once you get a call for motion, you go and pass the motion after relaxing the sphincter. So the rectum is the organ where the stool gets stored, and they go through the sphincter, that is the ring shaped muscle at the lower end at the anal canal, which keeps the continence. That means which keeps us continent. We are not able to pass a motion unless we are in the bathroom or we are in a comfortable position where we want to pass a motion. The sphincter controls mechanism holds the stool back till we are comfortable. So how does this colorectal cancer starts? So if you see the colon from outside, it is like a tube. It is long, 1.5 meter long tube, but it has got various layers. And if you can see that at the circle, at the center of a circle, there's something called as the epithelium, which is the innermost layer, and from where the cancer starts. Epithelium is the part where the cancer starts, and 95% plus cancers, they start from the internal coating, that is called as epithelium. And that's why they can't be seen from the outside. And to make them see, we have to go inside the lumen and get the testing done, and we can diagnose them early, which is called as colonoscopy. So 95% of our cancers, they come from the internal layer, which is called as epithelium. The colon has got many other layers like connective tissue layers. There's submucosa below that. There are thick muscles also. This muscular layer helps to propel the food or to push the food from the small intestine, taking it and reaching it towards the rectum. So this muscular layer is also important. There are very rarely some kind of cancers arises from these muscles or other submucosa and other loose tissues around. But as I told you, 95% of the cancers, they arise from the epithelium. That is the innermost layer. Now, what is a polyp? Because this is a very important thing. Normally, the cancers go through a sequence. Initially, the normal mucosa, and with the sorry, yeah. So now initially there is a normal mucosa, and in the normal mucosa or internal epithelium, this kind of outpouchings form. These are called as a polyps. Okay. And polyp is nothing but the outgrowth or extra growth of a tissue. You can see on the left side, this is a cut open colon in a virtual image, where you can see the multiple polyps inside. And these polyps are nothing but the outgrowth or the overgrowth. And if you do colonoscopy, they look like that. Internal coating is the plain coating. It has got some rings, some muscles, but you can see this center, there's a polyp over here. This polyp has got a potential to convert over a period of a time to a cancer, and then it starts spreading. So polyp is a very important thing which we look for in the colon cancer. Most of the polyps go into the sequence of getting to the cancer. How does this happen? Okay, you can see that from left to right, there's a hyperproliferation. That means the normal coating, this is the internal coating, and this layer is the internal layer of the colon, where the small pouching comes. This pouch goes on increasing, it becomes a polyp. The polyp is this what we just saw. Now polyp started developing a cancer, and there's an abnormal tissue growth happens. Now to grow these tissues, they need, because the cancer cells are rapidly growing cells, and they need blood supply. And that's why once this abnormal cells start, this is called as a dysplasia. The blood vessels started coming from below, and slowly the blood vessels increases, and cancer started becoming growing, and it forms the adenocarcinoma. It is a cancer. So this stage where they come very close to the blood vessels, and when they breach the internal layer of a mucosa, that time it is called as the carcinoma or the cancer. This is the early cancer, and this is the invasive. That means it has invaded through the muscles, and it is coming out of colon. It starts from inside and it is coming out. So this is the invasive cancer, which is a high grade cancer. So this is the process through which The slowly the normal internal epithelium becomes the polyp. Polyp becomes to abnormal growth. Abnormal becomes to the cancer, and then invasive cancers. This is the way normally the colorectal cancers go. So it is very important to diagnose them early when they are in this stage. Once we diagnose them early, we can treat them early and we can avoid them going towards the cancer. But remember that not all the polyps turn to cancer. There are different types of polyps are there. Very few polyps have got a tendency or potency to convert them into the cancers. Some types of polyps can change into cancer over a period of a time. Generally, it takes years. Years means normally on an average, 3 to 5 years is a time where we can see that these cancers, the polyp can go into the phases of changes and can become a cancer. But remember that not all the polyps become cancer. As I told before, there are many other types of polyps which are benign, they are non-cancerous, and they can be just left alone. If they are very big size, we can keep checking them by doing a scopy and keep them under surveillance. But benign polyps are normally not cancerous and they don't need any surgical intervention. The chances of this polyp converting into the cancer, it depends on the which type of polyp it is. And there are different types of polyps, as I told. But the adenomatous polyp, this is a special type of polyp where these polyps sometimes can convert it into the cancer. And because of this, these adenomas or these adenomatous polyps, they are called precancerous conditions. So when there's a precancer conditions means whenever there's a polyp, it is not a cancer right now, but when you see a polyp, we must remove them. You check them, and if it is an adenomatous polyp, then definitely we should keep them under check, surveillance, and there are chances that they may convert into the cancer. Not all the adenomatous polyps convert into cancer, but yes, definitely these are the only type of polyps which have got a potential cancer, potential for getting into the cancer. In this adenomatous polyp, there are three types of polyps. We call it the tubular, villus, and tubular villus. Of course, the tubular is little better type, and chances of getting to cancers are around 1 to 3%. The villus has the worst type, where there are 30 to 40% of these villus adenomas can get into cancers, and tubular villus lies between 3 to 30%. So they are mixed. Now, there are some other types of polyps, as I told you, which are benign, like there are something called as inflammatory polyps. There's something called as hyperplastic polyps. So these polyps are essentially benign. We just scope them once, we take a biopsy, we diagnose them by a biopsy that these are hyperplastic or inflammatory polyps. And most of them would not need any kind of interventions unless there's some symptoms like a bleeding or they're very big size causing obstruction. Only then we treat them, otherwise we don't treat them. What do you mean by high risk polyp? When you see a polyp on the endoscopy or surveillance, if polyp is bigger than 1 centimeter size, it is a high risk polyps. If there are more than 3 polyps found, because colon, as I told you, is very long organ, 1.5 meter long. If there are more than 3 polyps found, yes, then they are high risk. And if the polyp has got some abnormal tissues, where the lining of the colon and rectum looks abnormal, but they still haven't become cancers, they are high risk of a cancer. So polyp more than 1 centimeter, more than 3 polyps, and dysplasia, that is abnormal cells seen, are the high risk polyps, and we should always remove them, and we should always keep them under check because they have good chances of getting into the cancers. Now, how does this colorectal cancer spread? So as we discussed, they start from inside coating, and slowly they grow both the sides. They grow inside the lumen as well as they go into the wall. In the wall, there are few systems. There's something called as a blood vessels are in the wall, and there are lymph nodes. Lymph nodes means these are one of the system where some of the proteins are traveled by these small tiny vessels. Okay, like they are like a blood vessels. They are a bit smaller than the blood vessels, but they have got something called as a nodes, and these nodes are very important. These nodes generally goes along the arteries and the blood vessels. So once the cancer which grows inside has got no problem, but when it goes into the muscle, they tend to invade these lymph nodes. They tend to go to the blood supply, and through which they can go to the body. So that's how the cancer spread. They spread inside the lumen. There's no harm to patient, but once they spread into the wall of the intestine or the colon, they invade the lymph node and the blood vessels, and through which they go into the blood, and they go to the other organs. And that's why we call them as a metastatic or advanced cancer or the spreading cancers. So this is a process where it takes some time. Normally the size of a tumor and the depth of invasion correlates with the how they are going to spread the cancer out. What are the types of colon cancer or the rectum cancers? Okay, so as we discussed, most of the cancers, 95% cancers comes from the internal coating, and they are called as adenocarcinomas. Adenocarcinoma is the most common cancer, but there are other cancers which can also arises from the wall of the colon, and wall of the colon has got lot of things. They have got some muscles, they have got some cells, they have got some lymph nodes. So there are some special cells in the intestine from which the carcinoid cancers can come. Carcinoids are little better type of cancers. They have got a better prognosis and a long longevity as compared to adenocarcinomas. Adenocarcinomas are very aggressive. Second, there another special type of cell called cell of Kajal, through which something called as gastrointestinal stroma tumor. They also have got a better prognosis, but once they spread to the other organ, then they behave as badly as the adenocarcinomas. There are lymphomas, like they come from the immune system, and lymphatics, which we have just showed. They are lymphomas, and sometimes they are tumor or sarcomas, which arise from the blood vessels, muscles. They are called as sarcomas. Sarcomas are generally very aggressive. Lymphomas are normally not that aggressive. Adenocarcinomas are aggressive, but carcinoid tumors and gastrointestinal tumors are not that aggressive. But as I discussed, adenocarcinoma is the most common type of cancer. How common is this colorectal cancer is? So colorectal cancer is the third most common cancer diagnosed in the men and the women in the world. It is the third most common cancer, and it is the second most common cause of cancer related death in the world. So it is a pretty common disease. If you see, we don't have a national registry, but if you see American Cancer Society in 2020, this year, they estimate to found 1,06,180 new cases of a cancer, a colon cancer, and 44,850 new cases of a rectal cancers. So overall, almost 1.5 lakh cases of new patients diagnosing colorectal cancers in America they're expecting in 2020. So you can imagine this high cancer load. This is the third most common cancer and second most common cause of death because of a cancer. So this is pretty common cancer, and that's why March 2022 it is declared as a colorectal cancer awareness month. From 2012 to 2016, its incidence has increased every year by 2%, but primarily they are younger than 50 years of age and 1% in older patients. So if you see the young patients, the incidence of cancer is increasing now, and every year the increase is by 2%. If you are less than 50, and if you are more than 50, then this is around 1% per year. If you once you cross 65, 70, then the risk further goes down. So this cancer is slowly coming more in younger patients now because of our obviously Western lifestyle, the kind of animal fat that we eat, and there are many other factors for that. Overall, the lifetime risk of developing colorectal cancers is about 23. That is 1 in 23 for men and 1 in 25 in females. That means the risk overall in a lifetime getting a cancer chances for any particular individual, if it is a male, it is a 4.3%. If it is a woman, it is around 4%. So again, not to scare, but 96% chances that may not get cancer, but 4%, which is a very big risk to get this cancer. That means every 4 patient in 100 is going to get the colorectal cancer. This is a lifetime risk for the people. What are the risk factors? What are the risk factors which we see, which are mostly responsible for these factors, cancers? So we divide these risk factors into the two. We call them modifiable and non-modifiable. Modifiable means which we can change, which are in our hand, in our control. If we change it, we can modify it, like being overweight or obese. There are very high chances of a colorectal cancer death if patient is obese and overweight. It's a very important risk factor, and which is also modifiable, where we can reduce the weight and obesity, and we can control or we can decrease the chances. Not being physically active, mainly in young patients. Why we see these young patients coming with the cancer? Because nowadays our job profiles are such that there's no much physical work. Mostly desk job, sitting job, and there's no laborers work involved, and that can be one of the risk factor which is for the colorectal cancer. There's certain types of diet, like red meats such as beef, pork, lamb, or liver, especially in the non-vegetarian people, there is a more risk. The processed meat, nowadays we get a lot of processed meat, hot dogs, some luncheon meats, or sometimes also we eat some burgers, some pizzas, which has got some unsaturated fatty acids. Thus, the cook which has been cooked at a high temperature, like fried food, grilled or boiled. So all this Western lifestyle, these are type of diets where we can expect this to be as a risk factor for the colorectal cancer. Other than that, the smoking is very important risk factor. Smoking can lead to 31 types of cancers along with the colorectal cancer. So most important modifier risk factor is smoking, and of course, moderate to severe drinking of alcohol is also a risk factor for the many cancers. The risk factors which we cannot modify, these are the being older, hello, yeah. So these factors which are non-modifiable being the older age. The cancer is common after 50 years of age, which we cannot modify. We cannot modify our age. If you have got a personal history of colorectal cancers or polyps, which carries high risk of almost 15% risk is more as compared to normal population. A personal history of inflammatory bowel disease. These are certain diseases which is called ulcerative colitis or the Crohn's disease, where there's a chronic inflammation happens into intestine, and the risk, if the disease is 10-year-old, the risk is around 2%, but 20 years old, the risk is 7%. And if it's 30 years disease, because these are lifetime diseases, the overall risk is around 20%, which is pretty high. A family history of colorectal cancers or adenomatous polyps also carries the history. If you have got any family member, especially the first degree or second degree relative, then definitely the risk of colorectal cancer is high, and the risk can be 2 to 3 fold as compared to the common population. There are some inherited syndromes where these are something called as a the genetic risk of cancers because of some gene mutation. Around 5% of people all over the world do get this genetic inherited syndrome through which the family members get affected of cancer. And of course, the Africans, the racial and ethnic background, like African peoples, some Jews are at more risk. There's very small chance that type 2 diabetes, which is also this factor, which we cannot modify. What are the symptoms and signs? How they produce? So most common symptom is the altered bowel habits, where there can be increase in constipation, or constipation alternate with the diarrhea can be a primary presentation. Sometimes you get the blood in through the stool. There's a loss of appetite and weight. It can be abdominal pain or the colicky pain, and weakness, asthenia. These are all symptoms and signs of the. These are all symptoms of the colorectal cancer. And signs you may get, there can be anemia, unexplained anemia, low hemoglobin. There can be some lump or bump in the abdomen. Sometimes the liver is palpable. And if you do digital examination, that is, if you do a per rectal examination, that is a finger test, inserting the finger inside the rectum or anal canal, we may feel some mass there. So how do we diagnose the cancers, colorectal cancers? The blood test, which might show you a low hemoglobin or anemia, which can be a small trigger. There's something called as a tumor marker. These are the cancer markers which are secreted by the cancer cells in the blood. It's called as serum CEA level. It is a calcio and embryonic antigen. It is also called as a liquid biopsy, where we can do a blood test. We can see that the tumor markers are raised. If they are raised, then they help us for the diagnosis. Also, these we can keep a follow-up patient when we are treating these cancers. Tumor marker help us how the patient is responding to treatment, that they're settling down, they're coming down or not. So it is very important follow-up marker too. The stool for occult blood, it has got a very high accuracy. And when we do a stool test, you can see some occult blood which is sitting to the stool from the colon cancer, rectum cancer, and which has got a very high accuracy. And sometimes the sonography can show abnormal mass or abnormal lymph node, which normally at the higher stage. The colonoscopy. Now, how do we do colonoscopy? Colonoscopy is the test where we put a telescope into the rectum through anal canal, and we go and examine whole of the colon. You can see it's a very good investigation. A lot of people get scared when somebody advises you colonoscopy. It is a very simple test where we can go into the colon. We can examine throughout the colon of 1.5 meter by this telescope, and if needed, we can take a biopsy. We can also remove, if see a polyp, we can remove the polyps. but this is a test which we should not be scared of. A lot of patients feel uncomfortable to go for colonoscopy, and we then miss the opportunity of treating them. These colonoscopies are done as a daycare procedure. We don't need admission. We go in the morning, we do colonoscopy, we take a biopsy, and we can come out, we can diagnose them. The colonoscopy helps to diagnose the cancer. That is first most important thing. Second thing, we can also take a biopsy, so we can confirm that 100% is the cancer. And third and most important thing, colonoscopy can also tell you about there any other lesion, synchronous lesion. The cancer can be at two places because the intestine length is quite long, and cancer can be seen at two places. So definitely the colonoscopy can be helpful to map the colon. How will we stage the cancer? The staging of a cancer happens as a stage 1, 2, 3, and 4. And stage 1 is limited to the inner layer of a colon, which is curable. Stage 2 is involving the full thickness of a colon, which is also curable. But stage 3 is involving the lymph node around the colon, which is potentially curable. Definitely still there are options of curable. But stage 4, which is last stage, which is highly uncurable, which spread to the other organs. As you see the stage 1, 2, 3, and 4, as we progress, so the cancer spread into the wall of the colon, it comes out of a colon and it goes to other organ. So stage 1 is the best stage where we can cure the patient. How do we stage these cancers before treatment? How we treat them? Normally, we do a CT scan of a chest, abdomen, and pelvis. This is the best method to stage the cancer, where we can see that they have gone to the lymph node, they have gone to the inner organ, or they are limited or restricted to the wall of the intestine. So after colonoscopy, if the cancer is there, we stage them by doing a CT scan of a chest, abdomen, and pelvis. PET CT scan. Normally, people ask if can we do a PET scan because they have been referred by somebody. PET scan, if you say cancer, the PET scan will detect it. PET scan is not always needed. PET scan has got specific indication because it can be a false positive. Sometimes some infection like TB or some abscesses also light up on the PET scan, and we can misdiagnose them as a cancer. So PET scan has got a very specific indication, and it is in highly suspected metastasis, we can do PET scan. If biopsy is not possible, then we can do a PET scan. If there are some liver mets and we are planning for some curative options, we can do PET scan. It has got a very limited indications. Not all the patients we do PET scan, and that's why PET scan is not must for staging the cancer. What are the treatment? Surgery is the backbone of treatment. As I'm a surgeon, surgery is the most important thing. Without surgery, we cannot cure the colorectal cancers. In colonic cancer, now the colon cancer and rectum cancers, in colonic cancers, after surgery, chemotherapy can be used in stage 3 all and some of the stage 2 cancers to decrease the future recurrence. But in rectal cancers, chemotherapy with or without radiation also can be used in stage 3 and some of the stage 2 cancers. But surgery is the backbone of these cancers. Along with the surgery, rarely chemotherapy or chemotherapy may be needed. Stage 1, only surgery, it is a curative. Stage 2, surgery may need chemotherapy in a curative option. Stage 3, surgery plus chemotherapy, it is a potentially curative option. But in stage 4, only chemotherapy, which is not a curable option. Okay. How do we do surgery? Surgeries are there various ways we do surgery. The open surgery, the laparoscopic surgery, robotic surgery. I personally do all these kinds of surgeries, and all the surgeries are equal good, and it has got its own benefit. It's not that one surgery is better than other, but nowadays, yes, laparoscopy and robotic surgery is in a big way, and it has given us a good help to a patient to recover them faster because there's no big incision. A lot of patients get scared whether it's possible to remove colorectal cancer by laparoscopy or robotic, how safe it is. They ask question whether it is the complete cancer will be removed or not. So there are many studies which has proven that the laparoscopic surgery and open surgery has got equal oncological safe, and they are basically oncologically same as the open surgery. It's a very safe surgery. Laparoscopic surgery is standard of care in all Western countries and in Southeast Asia. Also, it is standard of care in many centers in India. And of course, at Hinduja Hospital, all these colorectal cancer surgeries, we do laparoscopic, robotic, and depending on situation, we take a call. But definitely, these surgeries are very safe, very good by laparoscopy and robotic, and when we should not hesitate to undergo laparoscopy robotic surgery for colorectal cancers. Robotic surgery is now a standard of care at Hinduja Hospital. We do robotic cancer surgery because robotic surgery has got many advantages. The precision is very high. Safety and adequacy is also well proven. and robotic surgery gives a high precision cancer surgeries, and now it will be a standard of care in the future. And if possible, if the option given by due consultation with the surgeon, robotic surgery can be opted for the colorectal cancer. Here, the robotic surgery, the robot is at the patient bed, and the surgeon sits on the console next to the patient, and through which the moment we do the surgery, very safe, very common nowadays, and precision is perfect. Of course, there's a difference between laparoscopic robotic versus open surgery. You can compare the wound. The laparoscopic or robotic surgery has got a very small half centimeter, 1 centimeter wound vis-a-vis the big, long, painful scar of open surgery. So as far as the option there, laparoscopic robotic surgery is a score soar in terms of patient pain, patient compliance, recovery of a patient, less pain, less analgesics, less stay in the hospital. So laparoscopic robotic surgery has got some advantages as compared to the open surgery. So how do we, can colorectal cancers can be prevented? Yes, colorectal cancer screening can be done for the population. That is, every yearly we can do a stool test for occult blood. Every 5 yearly we can do sigmoidoscopy, and every 10 yearly we can do colonoscopy after 50 years of age. So this can be done for the normal population, and those patients who are high risk, like those patients has got a cancer and initially had a cancer, now treated, or those got family history of cancers, they should do a close colonoscopic surveillance starting at early as age of 25 years. And if positive finding, then every yearly colonoscopy, and yes, they can be prevented. So yes, colorectal cancers can also be prevented by some modified risk factors. Yes, modified risk factors can prevent the cancers. You might be able to lower the risk of colorectal cancers by modifying your diet and the physical activity. Staying at healthy weight may help to lower your risk. So weight loss has to be there. The regular moderate to vigorous activity can lower the risk. So activity level should be high, and diet, overall diet that are rich in vegetables, fruits, whole grains, low in red and processed meat probably will lower the risk of colorectal cancers. Of course, no smoking and no alcohol will significantly lower the risk of cancer. Thank you so much for the wonderful seminar and listening and patience on there. If any there are questions there, I will be happy to answer. I'm available at Hinduja Hospital on Tuesdays and Fridays. My timings are on Tuesday 10 to 12 and Friday 2:30 to 4:30. My OPD number is 2106. Thank you so much.